adjourn. Thank you. The question is that this House do now adjourn. Nicky Morgan.
Thank you, Mr. Speaker. I'm extremely pleased to have this opportunity to raise this important topic in the Chamber tonight. I should declare at the outset my position as the Vice Chairman of the All-Party Group on Mental Health. Mr. Speaker, the Government's recent mental health strategy stated that ill health represents up to 23% of the total burden of ill health in the UK, the largest single cause of disability. At least 1 in 4 adults will at some point in their life experience a period of mental ill health. For some, it may be a relatively mild one-off episode. For others, the first episode will herald a long-term relationship with the mental health services in all their guises. Such episodes, whether short-term or long-term, not only have a profound effect on the person suffering with a mental health condition, but also on their families and friends, many of whom will never have come into contact with these conditions or this part of the NHS before. At its most serious, a patient may spend a period of time in an acute care setting, either voluntarily or where they are detained under the Mental Health Act for their own welfare and the welfare of those around them. At such times, both the patient and their families and loved ones will expect them to be kept safe and secure whilst they are given the appropriate therapy and treatment which will enable them to resume their place in our communities. It is that expectation and the fact that it is sometimes not fulfilled which is the focus of this short debate tonight. In June 2010, shortly after I was elected as the Member of Parliament for Loughborough, I was approached by a constituent, Glyn Brooks, who told me about the tragic death of his daughter Kirsty. I appreciate that the Minister is unlikely to be able to respond to this particular case, although I have sent his office a copy of the coroner's report into Kirsty's death. But it is because of that case that I have ended up leading this debate tonight. Kirsty was a patient at the Bradgate unit at the University Hospitals of Leicester. Kirsty was able to escape from the unit using the frame of an external door to help her escape. Her escape was not dealt with as it should have been, and she was able to commit suicide before either the hospital authorities or the police found her. This has clearly been devastating for the Brooks family, and I would like to pay tribute to them, and particularly to Mr. Brooks, who contacted me to tell me their story. I would also like to pay tribute to the excellent coroner, whose report did, I think, help to answer the questions which the Brooks family had about this tragedy. I should say now that I have spoken to both the former and current chairman of Leicestershire Partnership NHS Trust, who administer the unit, and understand that work is ongoing to learn and act on the lessons of this case. As a result of this case being raised with me, I began to wonder how many other patients abscond each year from units run by our mental health trusts. So I submitted Freedom of Information Act requests to all 58 of the mental health trusts in England. 57 have replied to me, and the figures make grim reading. Now, I should say, Mr. Speaker, before I go into the figures, that this exercise has also shown me that there is a real variety in the record keeping at the trusts. And there also seems to be a real difference in the way in which the term abscond is used as the basis of recording the relevant information by those trusts. And I hope this is something that the Minister and the Department might be able to help with. The Mental Health Act 1983 defines abscond as where a patient who is liable to be detained under the Act either absents himself from the hospital without leave granted under Section 17, fails to return to the hospital on any occasion on which, or at the expiration of any period for which leave of absence was granted to him, or absents himself without permission from any place where he is required to reside in accordance with conditions imposed on the grant of leave of absence. In responding to my request for information, some trusts used this definition, while others made the distinction between a patient who was absent without leave, absent without explanation, missing, or escaped. In addition, some trusts use the term AWOL and abscond interchangeably without definition or explanation. Other trusts use abscond only, but do not define what is meant by this term. And finally, some trusts provided to me the number of incidents of absconding rather than the number of patients. Others did not make this distinction. However, for simplicity, the figures I will now mention refer to the total numbers given for the 5-year period which I asked about, and therefore do not distinguish between the different types of absconding incident. My research showed that in the past 5 years, around 40,500 incidents of absconding occurred. This ranged from a total of 3 incidents reported to me by Barnet, Enfield and Haringey Mental Health Partnership Trust to 3,891 for Lancashire Care NHS Foundation Trust. There is a significant variation across the country, so clearly some trusts are doing things very differently to others. In the case of Leicestershire Partnership NHS Trust, the total figure for the past 5 years is 386. But as I said earlier, I must stress caution in comparing these numbers, as I think we could be in many cases comparing different things, although the overall effect of patients absconding is the same simply because the trusts use their own definitions, in spite of the fact that the Department of Health has published its definitions of absconding and escaping.
Would my honourable friend allow?
Of course.
I don't know where on her list the Hampshire Partnership NHS Trust figures, but did she find any correlation between the quality of the infrastructure of these units and the numbers of people absconding? Did she find, for example, that a brand new unit, such as Woodhaven in my constituency, tended to have a lower rate of problems of this sort? This is of particular interest as that 8-year-old hospital is threatened with closure, as I will be debating later this week.
I'm very grateful to the Honourable Gentleman. In fact, I have seen the subject of his adjournment debate, which I know he will be raising in the House later on this week. Unfortunately, I didn't have an opportunity to go into that level of detail, but I am going to come on to look at the quality of care and the fact that it has a huge impact on the absconding rates for patients. And I do think, as I'm going to come on to mention, this is something which the Department of Health and the Trust could work together on with all interested members of the House of Commons and anybody else interested in this particular area to make sure that see the link between absconding and the quality of care given. And there's no doubt there are innovative ways of ensuring that patients do not feel the need to abscond, or if they're outside the environment, they come back in because they know they're getting therapeutic treatment in that environment. As I was saying, despite all the caveats, I think these numbers are simply too high for organisations which basically owe their patients a duty of care. The fifth agreed objective in the government's mental health strategy launched earlier this year stated that fewer people will suffer avoidable harm. People receiving care and support should have confidence that the services they use are of the highest quality and at least as safe as any other public service. This is, of course, an objective that anyone who has an interest in any health service, but particularly mental health services, would want to see met. And the fact is that there is guidance in place already for mental health trusts and those working within them to follow. Although it would be fair to say that a lot of that guidance deals with how to react to an incident of absconding, rather than offering concrete guidance on prevention. In the case of my constituent, the coroner expressly found it would appear that the hospital had a system and policies in place to protect and supervise Kirsty from harm, but at all material times, those caring for her did not follow those policies. This is just not acceptable. The Minister will remember the long sessions earlier this year discussing the Health and Social Care Bill in Committee Room 10 upstairs. How could we forget them? One of the recurring themes was not just that we all want to see high quality services, but how do we ensure our health and social care services are high quality and that everyone is focused on the primary objectives of the health system? Do we do so through inspections? Do we hope that everyone working within the health system works to their own high standards, as many thousands of employees surely do? Do we ensure that there is guidance which is not only available, but followed? And do we ensure that when things go wrong, as in the case of my constituent, thorough investigations follow and lessons are learned? Surely it must be a combination of all these things. As I mentioned earlier on, hospital wards are meant to be places of therapy, but too often, especially in the case of mental health wards, they are anything but. In a recent report, the Centre for Social Justice said, hospitals tend to be untherapeutic and dangerous places. In helping me to prepare for this debate, Mind sent me a note which said, the quality of care quite clearly has an impact on a patient's decision to abscond. Unfortunately, as Mind's forthcoming acute and crisis care campaign will show, people in inpatient settings often experience substandard quality with no meaningful activities, little or no interaction with staff or each other, and at worst, lack of safety, abuse and coercive treatment. Kirsty's father has said to me, yes, of course I will.
Thank my honourable friend for giving way. Would you not agree with me that actually part of this and part of the campaign she's just raised, and I think she's done very well in bringing this debate this evening, is the fact that people often become labelled when they are in a mental health care setting. And actually what we need to do, if we're going to deal with this issue properly, is to break down and challenge those labels and see that actually the patient is not a mental health patient, but they're still a person, and actually all these therapies she's talking about, all these preventative measures relate to that, and if we can get that right, then we're actually going to look at people and treat them in the way they deserve, and with that respect, and that will actually help prevent these episodes of escape or absconding, as she labels them.
I entirely agree with the honourable gentleman, who obviously is qualified within the NHS and knows far more about these matters than I do. But everything he has said is exactly, I'm going to come on to that, but it exactly points to the fact that we must not forget there are people at the heart of all these cases, both the patients, but also their families too. And the sooner they receive good therapeutic treatments and they're able to, as I say, resume their place within society. And he also mentions another very important point, which is the fact that for too long, having a mental ill health condition has attached a stigma and people don't talk about it. And that's why I hope that tonight's debate is the start of us discussing it more openly in this House and beyond. As I was saying, Kirsty's father said to me that he believed there was nothing to do at the unit at which she was being treated. He said to me there were no constructive therapies. And Rethink and the Royal College of Psychiatrists drew my attention to a 2010 report prepared as part of the National Confidential Inquiry into Suicide and Homicide by People with Mental Illness, which found that between 1997 and 2006, absconders accounted for 25% of all inpatient suicides and 38% of suicides that occurred off the ward. Absconding patients were also significantly more likely to have been under high levels of observation, but clinicians reported more problems in observation of those who had absconded due to ward design or other patients in the ward. The report makes 3 recommendations for improvement. Staff need to pay better attention, not just to patients but also ward exits. Improved observation methods, as there is little evidence regarding the protective effect of close observation, and high levels of observation may be ineffective for people intent on leaving the ward, and increased focus on engagement and support by staff on admission. But as Mine pointed out to me, as we've already heard, there is evidence that where wards take a more innovative approach to inpatient care, they see reduced incidences of both aggression and absconding. So there is already an incentive for our mental health trust to do better in the treatment and care they offer their inpatients. In conclusion, Mr. Speaker, I would like to draw all these thoughts together. First, we need more research to understand the scale of the problem. The information I have obtained is, I hope, a good start, but I think that the department could insist that trusts use one set of definitions so that numbers can be properly compared, and those trusts with low incidences of absconding could share their experiences with those whose absconding rate is much, much higher. The department could also insist on the publication of the information which I had to obtain under the Freedom of Information Act. Secondly, trusts need to not only follow guidance which already exists, but also work out how they can do their best to prevent patients, when they are at their most vulnerable, from absconding and causing harm to themselves. My office did not have to look very far to find 7 newspaper reports of patients who had absconded this year. 6 of these cases tragically ended up with the patient taking their own life, and in one case the patient killed someone else. Only by encouraging trusts to take these steps will the department, I believe, stand a chance of fulfilling the 5th objective in its laudable mental health strategy. And finally, I would like to ask all of us to remember that at the heart of this are usually very ill people and their families. As Mr. Brooks said to me in July this year, we trusted the system, we paid our taxes, and we expected the best care for those who are at their most vulnerable. We talk a lot in the House of Commons about physical health outcomes, but the time has come for mental health to get a proper look in. As someone speaking at one of the all-party meetings on mental health said, we all have mental health, it's just that some people's is better than others. Because we are talking about people, there are no absolutes, and there will always be those determined to take their own lives. But I hope that tonight, by focusing on one part of the mental health system, the security of those patients being treated in hospital settings, this House can begin to make clear its desire to see real parity between physical and mental health conditions, the way they are resourced and the way they are treated. If we don't do this, I believe that we really are storing up huge trouble for this country, and there will be more tragic deaths of patients like Kirsty, which could perhaps be prevented.
To the debate, I call them